behalf of the National Network of Public Health Institutes, it's my pleasure to introduce you and have you on our show, Dr. Fraser. Congratulations on your important work and impressive accomplishments. And special thank you to our listeners. Welcome to the NNPHI podcast series. I am Vincent Lafronza, President and CEO of NNPHI, and I'm energized today. So glad you all joined us for this series. So let's just dive right in. Dr. Fraser, please tell our listeners more about yourself and your background and the work you do with community health centers.
Well, I ended up here through a circuitous path. Suffice it to say that this was my last clinical rotation with Dr. Smith when I was a senior medical student. I subsequently went off to train in surgery and urology. After that, I practiced here in town in Jackson for about 32 years, after which I was medical director for United Healthcare, the Medicaid portion, what they called the community health division. And then shortly thereafter, I came here just to see patients for a few days, but with the illness of my predecessor, I was drafted to step into the position. So I'm working in a slightly new and different world, having come from completely private practice to the world of the FQHCs, CHCs.
Great, what a history. So can you share a little bit about the brief history of Community Health Center as a model?
These centers were born of the civil rights movement. And my understanding from extensive discussion with Dr. Smith, who is likely the last surviving founder of this whole movement, my understanding is that the initial goal was to provide medical care and coverage for civil rights workers coming into Mississippi in the early 60s. But those people, so that meant that a number of physicians from elsewhere came in, volunteered, and were here to do that. But they couldn't ignore what they saw. They couldn't ignore the plight of the people that the civil rights workers were coming to help. And what they found were deplorable medical conditions, deficiency in medical care, lack of medical care, I should say, with the resultant impact upon that population of people. What you have to understand is that this happened at about the time when cotton no longer needed bodies and people to be produced. So there were, literally thousands of people increasingly left without work. No chopping, no planting, chopping, picking of cotton. All of that was becoming mechanized, and those who could migrated away, and those who were left were in deplorable conditions. And so this is what those healthcare professionals saw when they came to Mississippi, mainly to help initially to help the people who were volunteering in Mississippi. And so that resulted in some seminal thought and the development of programs to address not only the medical needs, but it was very clear from the beginning, particularly from one of the founders, Dr. Jack Geiger. The intent was to take on the whole, what we now call social determinants of health.
So if we move forward to today and we think about what we're challenging, what we are being challenged with, what are some of the infection prevention and control challenges that you have in community health centers?
Well, when I looked at that question you had, I interpreted it to mean, first off, one of the pressing things we had at the start of the pandemic, that was PPEs and securing the environment. So with regard to obtaining masks, face shields, goggles, gloves, gowns, jumpsuits, all of those things, there was some difficulty at first. We did receive some help through the Community Healthcare Association here, and as well as Direct Relief, and we were able to reach out to when our local suppliers, when our usual suppliers couldn't help us, there were some other relationships and local suppliers that we had. And we were able to cobble together enough equipment and protective gear to keep going. That was one of the first challenges that we faced. We also had to look at how we protect our workers and our patients who needed to come into the office. One of the things that Dr. Smith was adamant about was that we take care of so many people with chronic diseases, and telehealth sometimes isn't a sufficient option, sometimes isn't an option at all. And we still had to find a way to provide face-to-face visits for those people who absolutely needed them. So we had to find a way to keep going. And that brought up the question of securing the environment. How do we protect the clinic? How do we sort out who we can see and who we shouldn't, and how they're handled? So all those things were important. How do we clean and secure the environment, say at the end of the day, at the end of the week? And we were able to navigate through all of those things with some difficulty, some grant support, and somehow keep going. The other thing I would point out is that being insinuated in the community. So, and if you look at the original intent of community health centers and how they were organized, it's people from the community who really were expected to have a large say in how it operated and in operating it. And so one way that I've come to look at it is that those of us who work in this center are not too different from those we serve. The result of that is that we are at risk for the same things that our patients are. So we're at risk for COVID-19. We're at risk for chronic diseases that militate toward an adverse outcome from that disease. The diabetes, the hypertension, the obesity, all of those things. And I've come to view, us as providers as no different from those we serve. And maybe that's a healthy attitude to have.
Wonderful attitude. What role do community health centers have in the COVID-19 vaccination effort?
Well, I can describe our experience in Mississippi. Obviously, I read and see what's gone on around the country and what the issues have been. Our experience was that we were very late to get supplies. And to this date, we've received a total of 600, I believe, first doses. We're starting and these came late, so that next week we'll start our first round of 100 second doses. So that tells you how long we've been in play, how long we've been in the game. It's a little unclear what happened. I think obviously this was a process that was sensitive to politics and political pressures. There are a few CHCs that did get supplies earlier on and were able to begin to vaccinate their individuals in the community, but many were not. Many individual practices and providers were late to get supplies, and so it's caused that to be the rollout to be spotty, and the rollout for those people that we served most closely, to be deficient. Relative to the supply that we have no deficiency of people wanting to get it. So that we can, if we have the personnel to allocate to that effort, we can get them in and get them injected and use our supplies to this point quite efficiently. But it does take a toll in the normal operation of the clinic and what our core mission is. People are more comfortable coming to a place where they're used to getting care with providers they trust and are familiar with, and so we have to capitalize on that.
You mentioned the supply chain, so that's
Yes.
one issue. How can COVID-19 vaccine distribution be more equitable for heavily impacted populations?
Well, the first answer to this, and I'll let Dr. Smith comment. The first answer to this is that we have these community health centers who have relationships with individuals that we want to reach. And I think to find a way to capitalize on that resource, it's one of the first steps that can be taken. I think it can't go on alone. It has to go out with the outreach has to include education, has to include the right public relations, so to speak, and we have to overcome those barriers that I just talked about, the distrust, the concern about these things in the community.
The only thing that I would add to that question is that, but the last administration used the Republican philosophy of top-down, which was unfortunate and incorrect. It should have been bottom-up. And I say bottom-up based on the words that Dr. Fraser just mentioned to you. It should have involved community health centers who see people at highest risk, other local physicians, and medical establishments that have a relationship with patients that can answer questions that they may have if they have questions. That's number one. That was the first mistake they made. The second mistake had to do with the fact that they did not place the vaccine in public distribution centers for those people who had highest risk, which should have involved public centers, churches, and other major gathering places where people do have trust and don't have a lot of problems with access. And thirdly, and it seems to me it's been a no-brainer to vaccinate or attempt to vaccinate these people who are service workers, gig workers, whatever they are, ought to have been the first people, in addition to everybody who is over 75 and at high risk.
I would add that one of the things I've felt as this pandemic unfolds, is that we needed a clear message from top down. What is our policy? How are we going to get through this? We needed to be consistent from state to state, from municipality to municipality. This was rather a laissez-faire activity. Each state, had its own slant on what was a protective activity for its citizens. Each state has had its own way of pushing out the vaccine to its population. I think we would all have been, those of us who are providers and those of us who are citizens needing the vaccine, would have been better served by one consistent message that addressed all of our needs. I think that to some extent did result in the inequitable distribution of this resource.
So are there other lessons that you're learning about COVID-19, whether it's the vaccine distribution or the infection prevention and control work that we're doing in general as a society? Are there other lessons that you think are important to raise here?
Yeah, I especially want to lift up the fact that using the traditional methods, and I don't have to remind you what the policies of many of our states have been. I was invited to the White House conference in 1965 with President Johnson when he was trying to roll out Medicare and Medicaid. And I said to him back then that unless states have something to lose, they will never enact a Medicaid program because of the traditional policies of the state. Now, we have made some tremendous progress since that time, but unfortunately, when it came down to the COVID vaccine, we have been very selective, and selective to the point where we have continually unnecessarily, to have hospital admissions because the people who are most at risk are having the hardest time getting the vaccine, and specifically from the advice and traditional sources in which they are used to and trust. They certainly would have overcome many of these, well, I won't call it a myth, but everybody's aware of the Tuskegee experiment, but we have moved beyond that now. And I can tell you we have moved beyond that because if you are familiar with the atherosclerosis in communities area that was started 30 years ago, they thought that we were crazy wanting to do an all-Black center at the University of Mississippi Medical Center. But I was one of the principal investigators, and we got that program off the ground, and it's 40 years old. Based on what? Based on the fact that there were people involved at the ground level who looked like them, and I'm also a participant.
The problem of mistrust that we talked about was surprising, but I think part of it was the result of the environment created during the last 4 years.
So Dr. Smith and Fraser, for our listeners, as we wrap up this podcast today, are there any final pieces of wisdom you would like to share?
Well, Dr. Fraser has mentioned several, and he has mentioned one about expansion of Medicaid, which would give 7 to 8 additional thousand Mississippians access to care. People always talk about cost, and I'm aware of cost too, and I'm certainly aware of medical costs. But there can never be an excuse for not guaranteeing all Americans the right to good health care.
So that brings us full circle today, and as our nation celebrates Black History Month, the importance of our public health efforts have never been more valued by communities, especially those impacted by these inequalities and inequities in health status that we can and we must eliminate. Thank you both, and for our listeners out there, stay tuned for more NNPHI podcasts. Stay well, wear a mask, watch your distance, and engage in lots of self-care.